Thank you, everyone, for joining us, getting up early this morning and joining us here at the Baker Institute. Welcome. I see familiar faces, and then I see faces I haven't seen before, so I'm glad we've got a nice, diverse audience for this crowd. Let me do a little bit of commercialization for our upcoming events. Later in May, we have an evening event looking at Houston and its possibility for innovation in healthcare, so looking at tech startups and can that become something that can gain momentum, healthcare tech startups here in Houston. We also have a conference on human embryo research and looking at the ethics and policy issues behind that particular question. These are on our website. In June, I'm going to be doing my annual luncheon event, and I've decided to talk about drug prices and the relationship between drug prices and health policy. So that is coming up. And then in October, we're actually going to look at universal health care around the world. So we've got expert speakers speaking about Canada, the UK, Germany, and somewhere in Asia yet to be decided. So with that, it's a privilege to introduce one of our own non-resident fellows, Elena Marks, as the speaker this morning. Some of you, many of you, I'm sure, have enjoyed world-class healthcare treatment right across the street at the Texas Medical Center. Despite the level of care that is unmatched there, we all know that Houston ranks very poorly in terms of overall health status, and we have a lot of problems in this area. And it's really only because of people like Elena Marks that we have a fighting chance at addressing this issue and managing to dig us out of this hole. I've been here in Houston for 14 years. Elena has been doing healthcare in this city for longer than that. I was just very fortunate to meet her when I first arrived on the scene. She was really Mayor White's top person in terms of taking care of healthcare policy issues for the city early on during my career. So she was right here leading up sort of the things that the city was doing in terms of Hurricane Katrina victims, and has just kept on going in so many different roles. And she was the chair of the board for Community Health Choice for many years, and helped build that healthcare company into really one of the top providers of Medicaid managed care and marketplace care, and has since then become the CEO of the Episcopal Health Foundation. And she's going to, I'm sure, talk about the work she's done and how that relates to her particular topic. And she's been wonderful, really kind of roped me into doing surveys and writing about the Affordable Care Act and its impact on Texas. So with that, I'm going to get out of the way and welcome Elena Marks to the podium.
Thanks very much. It is great to be here. This was my home before the Episcopal Health Foundation became my home, and I guess I still have a home here. Vivian has been kind enough to keep me on as a non-resident fellow, and we have been able to do fantastic work together over the years, from the city days to my days here to my days at the Episcopal Health Foundation. So this morning, I'm going to talk to you about health and health care. We often think about them interchangeably, that if you get health care, then you're getting health and you'll be healthy. But is that really true? Do we know how much health care actually contributes to our health? We spend trillions of dollars a year in this country on health care. How is that actually impacting health? These are the questions I spend a lot of time thinking about, and what I want to do today is explore these questions with you. So I'm going to tell you a little bit about how I got to where I am in my thinking. So I started life as a lawyer, wearing a silly little tie like that. But I didn't think about health or healthcare at all. I just went about my business like most people do. Fast forward many years, and I ended up with an entirely different career that is just fantastic. So I've been doing some pro bono legal work for a community clinic that served low-income and uninsured people. And I got really interested in how people in that condition got access to health care. And a friend of mine was on the faculty at the UT School of Public Health, and she said, well, you ought to go get a degree in public health. And I thought back then that health care and health were the same thing, and that sounded great to me. I really thought public health meant publicly funded health care delivery, and I was really interested in who pays for health care, who gets it, and who decides. And so I went and got an MPH. Fast forward again, many years, I've had a bunch of great gigs in my life, but one of the best opportunities I had for real impact was working for Mayor Bill White as his health policy director. And Bill and I had a common interest in the questions about health care, particularly for low-income and vulnerable populations. And again, we talked about health care as if it was health. We used the words interchangeably. So this was 2004, and it was really scary how few Texans had access to good health care because of our high uninsured rates. And I was really focused on how do those people get access to basic health care. I wanted to work on that problem. I thought health care was health. And we did some great things while I was there at the city. We were able to bring up 5 primary care providers into city facilities and increase access to basic primary care for lots and lots of Houstonians. We also put in place a program that required big city contractors to either pay for health benefits for their employees or pay into a fund that the city collected, and the city then would use that fund to give to clinics and providers that served that population. And so I was really interested in that work. But over time, I began to question whether the medical services we were delivering was actually improving people's lives. I knew they were better off for having access to that care. There's no question about the importance of health care. But I didn't see wholesale uplifting of people's lives just because they were getting to go to a doctor. And so I knew health care was important, but was it really enough? And in order to figure that out, I had to ask myself one simple question: is health care the same thing as health? So let me tell you about health care. It tends to look like this. We get our ideas about it from TV, from the media. This is from Grey's Anatomy. Doctors rush in and they do these miraculous treatments, and these people's lives are saved. And because it's TV, nobody knows what happens to the patient afterwards, and nobody knows anything about who pays the bills for that. So when I think about healthcare today, when we see the images associated with healthcare, it's high-tech, it's invasive, it's urgent, and it's expensive. So then what is health? It's not the same thing. The WHO has a great definition of health, and basically what they say is that health is a state of complete physical, mental, and social well-being, and not just the absence of disease or illness. And it comes down to this: how long do people live and how healthy are they while they're living? Quantity of life plus quality of life. So think about that for a minute. Isn't health the end game? Isn't that what we want? And isn't that what we should be getting out of all of the money we invest in health? And does it? So let's see how the system works. Let's take a common case of back pain. You wake up one morning, your back hurts, you wait a couple of days, still hurts, you go to the doctor, you tell your story, and the doctor says, well, I don't know, it could be a lot of things. So the first thing you do is you go get an x-ray. Relatively inexpensive, non-invasive, but it's inconclusive. Then you up the ante a little bit, you go get an MRI, maybe you get a CT scan. By the way, what does an MRI cost? Does anybody know? Yeah, $400 to $4,000. So that's You have to be a very careful shopper. But those results come back, and they don't show anything. You're still in pain. You're really frustrated. You've been through the health care system, and they haven't done anything for you. You take matters into your own hands. You go to Dr. Google, and you're hoping that Oprah has come up with the latest, greatest cure. You're feeling really angry by now. You've missed work, and you're still hurting. Finally, it probably goes away on its own. A lot of back pain remits just by waiting, maybe by taking some ibuprofen. Or maybe you realized you were sitting too much, you're in the wrong chair, you were on a flight and something happened, or you figured out you probably shouldn't be running on concrete miles and miles at your age anymore. Or maybe you've gone to a physical therapist or to a personal trainer and you've gotten some simple exercises. But let's look back at the journey that you took to get there. It was expensive, it was intrusive, there were needles and dyes, you were locked up in a little tube, there were loud noises, you were exposed to radiation. But did the healthcare system actually deliver health to you? So let's look at how this multiplies across our system, the most expensive medical system in the world. So you might remember Malcolm Gladwell's story from 2006 called $1 Million Murray. Murray was a guy who lived in Reno, Nevada, and he had a lot of problems. He was homeless a lot of the times, he was an alcoholic, he smoked, and he basically got banged up in his life all the time. Ambulances would come, they would take him to the hospital, and he would get all sorts of medical services, and they'd patch him up, and then they'd send him back out. And he kept coming back in over and over again. And over a 10-year period, the costs were more than $1 million. He had CT scans, he had hospital stays, he had ambulance runs. And did the expenditure of all that money actually do anything to help Murray? It helped him at that moment. It got him from being in critical condition to back up on his feet, literally. But did it ever help him stop smoking or drinking? Did it help him live a healthier lifestyle? Did it help him live in a safe place? Well, of course it didn't do that. The healthcare system patched him up and sent him back out into the same conditions. But there are better things that they could have done for Murray. Some of this is a little funny, but it's actually true. We could have done any of these things, and it would have cost less than what we spent on Murray's health care, and it might have solved some of Murray's problems, but that's not how our system works. Our system is designed to pay for ambulances and hospitals and doctors to deliver medical services to Murray. And who's footing the bill? We're all footing the bill. Whether you're a taxpayer and you're footing the bill through local and state and federal taxes, whether you are a business and you are paying for health insurance for your employees, whether you are an individual and you're paying into this system either cash out of pocket or buying your own insurance, we are the ones who are paying for this. And so even though these solutions are cheaper and more effective, may actually fix Murray's problems, this is not what we reward. What we pay for is the delivery of health care, even when it doesn't deliver health. This is another case. This is Dolores Somerville. She has a child with really bad asthma. She lives in Baltimore, and she lives right by Johns Hopkins, which has a world-class asthma prevention research program. She calls 911 because of her son's asthma attacks so often that the operators know her voice. She takes him to the hospital, he gets treated, he gets released, and he goes back home. If anyone ever had a chance of getting fixed with asthma by the medical system, you would think it was Miss Somerville's son. But the root of the problem is not in her son's body, and it's not anything the clinic can fix. It's in their apartment. They live in an apartment that has mold in it, it has toxic chemicals, it may have infestation of pests. These are things that are fixed by changing carpets, spraying for bugs, using different kinds of cleaning supplies. But that's not what the healthcare delivery system pays for. And so we continue to pay for this little boy to go to the hospital and get all of these treatments, but we won't pay for him to get a clean living situation. It seems obvious that we should change the situation. We should be paying for health. But why aren't we making these changes? So I would submit to you that it has to do with how we think about the issue. So bear with me for a minute, a little exercise. So look at these statements, think about them, don't answer, but see how you react. Do any of them feel true? In fact, they're all true. Why do we have such a hard time getting our heads around things like that? Well, it's a funny trick that evolution has played on us, making us feel that way, and it's called cognitive bias. And it's something that messes us all up all the time. Cognitive bias is like a default reality filter in our brains that's calibrated to have us take notice of some things over other things. And it's evolutionary, and it was there in the first place to help us know where danger was so that we would avoid lions and things that might eat us. So we are hardwired to predict outcomes and benefits based on how these biases skew the way we see the world. Let me give you some examples. So one kind of cognitive bias is emotional reasoning. And this is what makes us feel that driving a car is safer than flying. There is a ton of data that shows that flying is much less likely to get you killed than driving a car. But people feel like they're on the ground, they're in control, and so they can make it work. People drive thousands of miles a year because they are afraid of flying because they think they're going to die from flying. And we continue to believe that even though it's not true and the data is not persuasive to us. Another kind of cognitive bias has to do with how much we see something, how available information is to us. And this is what makes us think that being a police officer is much more dangerous than being a fisherman. Because when police officers are killed, it's a tragedy and it's all over the news and it's unacceptable and it shouldn't happen. But it's got us thinking that being a police officer is a really dangerous job. And compared to being a fisherman, it's a walk in the park. But we don't see all of this information about fishermen dying. And so we go on believing, because this information is available to us, this gets burned into our minds, and this is how we think about the world. An even stronger cognitive bias is what's called the negativity bias. And this is the one that makes us give priority and keep in our heads things that are big and scary and unique because that settles into us. And that's what makes us think that we've heard about somebody who's had this exotic surgery when there were robots involved and it cost a lot of money and it was in this really cool space. And that's what we think of instead of thinking about the friend who had back pain and they waited a few days and they did some exercises and they got better. And we're inundated by images of this miraculous health care. And so cognitive bias fools us into thinking that health care is health and that if we get more health care, we'll get more health. So what does that do? Where does that leave those of us who use this healthcare system in our quest for health? Are we getting what we need? Are we getting what we paid for? Another set of questions or statements, take a minute to look at them and think about the fact that we spend $3.3 trillion on health in the U.S. each year. That's almost 20% of GDP. That is a lot of money. And for that amount of money, every one of these statements should be true. But they're not. They're all false. They feel true, they should be true, but they're all false, and I want to talk to you about why. So remember, if we measure health as the quantity of life plus the quality of life, let's look at the factors that determine quality and quantity of life. So this slide shows you information that was developed by the Robert Wood Johnson Foundation and the University of Wisconsin. Many of you are probably familiar with the county health rankings that come out every year. And it's actually the collection of really decades of research that look at what are the factors that actually contribute to how long people live and how healthy they are while they live. So the factor that contributes the most is the social and economic factors. And this contributes about 40% of what makes up your health. Next, after that, are health behaviors. That's obvious. We all know if you are smoking, drinking, using drugs, not eating a healthy diet, not getting enough exercise, you are setting yourself up for bad health outcomes. There's also the physical environment. This is where the housing comes in. You may be exposed to environmental pollutions in your home, at work, just in the outside environment. And last but not least is clinical care, 20%. So let's look at these factors and see how they line up with where our $3.3 trillion national health expenditure goes. So the column on the left is the same thing from the page before. It's the determinants of health, or the drivers of health, or the factors that lead to health outcomes. On the right are the national health expenditures. You can Google it. It's published annually. This is from 2016, and this breaks down the various categories that we spend as a country. So this is not just the federal government's expenditure. It includes state and local and private expenditures as well. And when you look at this, you can see that 97% of our $3.3 trillion is going to health care, to clinical care. That correlates to 20% of the factors that contribute to health. Little bitty 3% at the bottom, it's actually less than 3%, I rounded it up, correlates with health behaviors, which squarely falls in the public health realm. There are other factors that relate to the social and economic factors and the physical environment that also are within the public health realm, but let's just say this. So this feels right when you just look at the column on the right, because you say, yes, healthcare is so important. We ought to be spending so much on healthcare because it's getting better all the time and we need more of it all the time. And so that would be fine if we were getting our money's worth. This feels right to us. So what kind of health outcomes are we getting for this? Now we're moving to my favorite slide in life. Those of you who've heard me do this before, bear with me. I can't use it often enough. So this is work by Betsy Bradley, who was at Yale and now is the president of Vassar College. And she has been studying the spending patterns in countries around the world, particularly in developed countries. So what you see here is a column for 11 different developed countries. And what it's showing you is the percentage of GDP that each of those countries spends on health care. And so the U.S. is the one on the far right, and you can see that it spends the most, the largest percentage, and actually the largest dollars on health care. The dark blue part of each bar is the percentage of GDP that each of those countries also spends on social care. And so you can see that the U.S. spends the least on social care. The green line running across is life expectancy at birth. And what I take away from this graph is that we spend the most on health care, the least on social care. Our ratio is the most heavily weighted toward health care, and we have the worst life expectancies. I could pull that green line off and put on the line for infant mortality rate. How many babies per 1,000 die by the time they're 1 year old? We'd be the worst. I could do the same thing for obesity. We'd be the worst. I could do the same thing for seniors with multiple chronic medical conditions. We'd be the worst. So what do we make of this? The facts are in, they're conclusive, but they don't line up with the way that we think about health, the way it should work and the way it does work. We've been on this path for many years, investing increasingly in health care, and we know that health care investment alone is not going to achieve what we need to achieve. Why do we keep spending on something that isn't delivering what we want? We're spending all our money on this when this is what we want. Healthcare is just a means to an end. Health is the end game. So how would we get there? Let's talk about value. This is a standard equation. Value equals quality over cost. If you were buying a car, you'd think about it the same way. If you're going out to dinner, if you were buying a service, you want to know that your value is that the quality of what you're getting matches up with what you're paying for. And so let's look at it from the health system perspective. It's no secret that we're not getting value. Everybody talks about that all the time. So let's say this is our status quo equation. We are spending 10 in costs and we are getting 5 in quality. That value is not a good one. So what's keeping us from changing that equation? I would say it's cognitive bias again. It's not accepting that something simple, including time, can cure what ails you. It's thinking that all of the answers lie in an expensive, high-tech system. And it's also the fact that we worry that one day we or someone we know will need something that is very expensive, very unlikely to be needed, but we want to make sure it's there for us all the time, even if we're doing that at the expense of 90+% of what actually makes us healthy. We have put all of our health eggs into the health care basket when that's actually just one component of health. So what can we do about this? So if we start with this equation, and we want to move to a place where value is cost and quality are equal, we've got options. So one thing we could do is reduce the cost of health care. And there's a lot of conversation going on in this country today about that, and it's a really important topic. We are paying too much for health care, and there are a whole lot of reasons for that. So we could reduce the cost, and then we wouldn't be paying so much. We wouldn't be getting great health outcomes, but maybe it wouldn't bother so much. We'd say, you know, you get what you pay for. Because now we can't even say you get what you pay for. But does it have to be that way? What if we looked for 7/7 as the value equation? What if we reduced the costs, but we didn't cut them out entirely, and we redirected those costs so they actually went from the health care system to mechanisms that actually deliver health? Can't we improve quality at the same time? Does it have to be binary? What if the healthcare industry were responsible for health, not just medical services? Think about it, and what would that look like? So the slide you're looking at is a picture from a before and after. The before is on the left-hand side, and the right is on the right-hand side of an intersection in Oakland, California. Right near this intersection was a community health clinic, and the pedestrians in this area were constantly getting hit by cars, and they'd come into the clinic, or the clinic would rush out and take care of somebody. And so medically, the clinic was doing what it was supposed to do. It was helping people who were injured get better. But they took it upon themselves to solve the problem. And what they did was work with city planners and others in the community to get the intersection redesigned so that it was safe for pedestrians. Now, they weren't getting healthcare dollars for that, but they were actually improving the health of their patients and their community by doing this kind of work. They saw themselves as being in the health business, not just in the healthcare business. And I get to find ways to do work like this every day because I'm just fortunate to work at the Episcopal Health Foundation. Let me tell you a little bit about our foundation. Some of you know the story, but some don't. We were formed on paper in 2013 when the Episcopal Diocese of Texas, which owned the St. Luke's Health System, transferred that hospital system to Catholic Health Initiatives. And the proceeds from that sale were put into a newly created entity called the Episcopal Health Foundation. And when that entity was created, the bishop challenged us to think creatively, and he said, how can we really improve the health of people who live in the 57 counties? We've got 11 million people in our region. How do we improve their health? We aren't in the acute care business anymore. How do we take those proceeds and really innovate, and how do we move upstream? And so that gave us the opportunity to be creative and help the health care delivery system start delivering health. So you remember the story of the child with asthma in Baltimore. We have kids like that in Houston. This boy's name is Angel, and he lives in the Houston area, and he has severe asthma. And he was seen by a clinic who was really frustrated that they gave him all the medicines that he needed, but it wasn't enough. He was still having asthma attacks, and they approached us about going to the homes of patients like Angel and visiting in the homes and looking at what they could do to fix the conditions in his home so that he wouldn't have these attacks. This is the kind of work that we're funding, and we were so delighted that a health clinic would say to us, it's not enough that we're giving Angel medicines, we've got to help solve his problem. Another example, we have lots of million-dollar Murrays in Houston. This is Mr. J, and he is a client of a local organization called the Patient Care Innovation Center. And what they do is look for patients like Murray who bounce around the system. They go to multiple hospitals, multiple emergency rooms. EMS is picking them up all the time. Some of them are bouncing through the criminal justice system as well. And despite expending a lot of money, like they did with Murray, putting him in the hospital and doing stuff and sending them back out, what PCIC does is look at how they can improve not only the expenditures on Murray's health care, but Murray's quality of life. And so this slide shows you the outcomes for Mr. J. The before column is the one on the left, and the after column is the one on the right. And so what you can see here is that after the intervention, which essentially means assigning a person to Mr. J who helps manage everything about their lives so that they get into a safe living situation and so that they have the opportunity not to be bouncing in and out of the healthcare system. After they did that for a year with Mr. J, his visits were reduced substantially, the costs were reduced substantially, and perhaps most importantly, his quality of life really went up. He was able to achieve his own goals of living without being a burden on the system and suffering from poor health. And doctors can and are leading the way in this kind of work. They say they want to do this. We hear the frustration in our clinicians all the time when they understand the limits of medical care, and they're frustrated about it. And here in Texas, we actually have a phenomenal example in Austin of a new medical school that has reoriented its entire curriculum to focus on outcomes and health, not just health care. Now, they're still in the healthcare business. I don't want to pretend that Dell Medical School is not teaching doctors to deliver health care, but their entire orientation is based on what is the value to the patients they're seeing. So for example, if they have a patient with a cardiac condition, they begin with what is it that this patient wants to do in their lives. And so if the patient says, what I really want to be able to do is walk with my friends in the neighborhood, then they direct all of their plans toward what does it take to get this woman able to walk in the neighborhood. They don't look at what are all of the interventions we could possibly do to someone who presents with this cardiac condition. And they understand that that's the value in what they do, that it's not just the delivery of the medical service, it's whether or not this patient's quality of life, as they define it, is improved. So if you have a hammer, then everything looks like a nail. We are so focused on our healthcare delivery system that we think it's the answer for everything. But not everything is a nail. Can we get past the cognitive biases that keep us locked into thinking that healthcare is the only way or is the major way? It's a great tool, it's really important, but it's only a 20% tool. What can we do to make sure that our health care system delivers health? How can we incent them to do work that actually delivers value in health, not just in medical services? So I would say we're on our way to do that. We're doing it in this country, and we're doing it really slowly, and we're doing it from the perspective of healthcare costs too much. But that's the opening for those of us who want to say, yeah, it costs too much, but we're also, even if you reduce the cost, how can we improve the value in the sense that people get healthier? What we're trying to do at the Episcopal Health Foundation is accelerate that change. We want to see the health care system produce health. We think they need the appropriate incentives in order to be able to do that. But how do we get them to do that? That's where all of you come in. We all built the system. We told payers, we are payers, and we've said this is what we want. And so the system exists the way it does because we have not only allowed it to be this way, we have encouraged it to be this way. And so if we made it this way, we ought to be able to undo it. And the way to do that is for us to say we want to pay for something else. We don't want to pay for medical services only. Medical services are not inherently valuable. They are only valuable if they're delivering health. And we're really lucky in our foundation that we get to work with community partners and healthcare organizations that are interested in this kind of work. So as I stop speaking and engage with you today, here's what I'd like for you to remember when you walk out the door. We have the most expensive health system and health care system in the world, and we're spending most of that money on a factor that only contributes 20% to health outcomes. It's a trick of the mind that keeps us thinking that we've got to have all of our health eggs in the healthcare basket. We need to correct the incentives. Payers, we're all payers. We can change the game. You're funding health care, and you have a say in this, and you can insist on getting value in the form of health. And so I have one ask of you today, and it's going to sound really simple, but I would submit to you it's actually very profound. And that is that you help change the conversation. Listen to yourself talk, and when you say the word healthcare, catch yourself and think about, do you mean medical services or do you mean health? And be cognizant of that. If you can change your own mental model, if you change the way you think about the conversation, then you can change the way you behave around the conversation. And listen to others who talk about health or health care. And when they conflate the two, when they use the words interchangeably, it's an opportunity for a conversation that says, well, do you mean healthcare like medical services, or do you mean health like people are living long and are having a high quality of life? So if we can change the conversation, if we can get ourselves focused on health, not just healthcare, we can save money and we can improve health outcomes, and everybody in this room has a stake in that. So with that, I'm happy to entertain questions or comments, and thank you very much for being here today, and start talking about health, not just healthcare.
I love the fact that you brought up the cognitive bias piece, because I've heard a lot of this before, but that's a new element in that, so that was great. So thanks for doing that. I'm wondering about your thoughts around the penetration on managed care and capitation, because that's where I'm kind of being hopeful that as we look at that model and increased penetration, do you see it happening? Are you encouraged by that perhaps shifting this?
Well, I think that's where it can happen, and I have most of my experiences in the Medicaid managed care space, and we have the opportunity through those plans, if Medicaid will allow us, to pay for what gets people healthy as opposed to medical services. But there's still a bias within the Medicaid program for medical services, which is why you find that they will pay over and over for these people to be admitted to the hospital, but they won't pay to repair their home. And there are conversations going on in the country in the Medicaid space, also in the Medicare space, but it's slow moving but I do believe that capitation and managed care, if you say that these are the dollars you have and the outcomes we're going to hold you accountable to are health outcomes, not medical service outcomes, then that's a movement in the right direction.
Hi.
Hi.
Tell me how we move what you're talking about to basically a friendly audience, to the problems that we have with elected officials, both locally, regionally, nationally, who have a tremendous cognitive barrier, I would say, about this. They continue to believe that we are the healthiest country in the world, that we have the best. I mean, I've heard it for years and years and years. We still hear it. And I don't know how, I've always wondered how you get beyond that bias, that conviction that permeates elected officials, and therefore can make some of the changes that you're talking about, not just in definitions of healthcare and health, but the whole thing.
Well, that's a really hard question. I mean, I don't know what to do when we are working with elected officials who are not tied to facts. I mean, really, if somebody is going to rely on ideology over facts, there's no answer. But I would submit on the question of health versus healthcare, have these conversations with legislators. They hear from everybody, we want healthcare, we want healthcare, we want healthcare. They don't hear from everybody, well, we want value in health. That's really the value. I think that might be an easier conversation to have than say, yes, no, we actually don't have the healthiest population in the world.
I believe that over 20 years ago, capitation was introduced, which embodies a lot of what you spoke about today. Can you tell us why it was not more successful, has not been more successful?
Well, when it was introduced, I mean, there are people who know this topic much better than I, and they're sitting in this audience, but I'm going to take a shot at it, and Ken will correct me later. There was a feeling at that time that it was a radical change and that it was a ploy by insurance companies to maximize profits by reducing access to care. And once you've got that frame, it's really hard to talk about the opportunities there. As costs continue to escalate, and I don't even know what the percentage of escalation is since the 80s, but tremendous conversations that you might not have been able to have then, you can have now, and we're seeing that in Medicare and Medicaid. I don't see it happening as much in the employer-sponsored sector, and employers have a real opportunity here to structure their benefits in ways that are yielding health, not just more access to medical services that may not be necessary.
Elena, how do you factor into your thinking the fact that a really disproportionate share of our total healthcare expenditure takes place in the last 6 months of life?
That's a great question, and it's somewhat related. My personal opinion about why we do that is part of our American exceptionalism, and you're Canadian, so you're not flawed in this way, where we think that science can save anybody from anything and that we should just do the next big technological intervention. And that's the philosophy we've sold ourselves on at the expense of dying with more dignity. And I think Mrs. Bush's decision recently to go home, I hope opens that conversation for other people to recognize that having more and more interventions is not the only option. It's certainly an expensive option, but we've told ourselves that's what we should do. And so we have to tell ourselves, no, that's not what we should do. It's a cultural thing.
One of the aspects of health, of course, is our spiritual life, and Episcopal Health Foundation is basically a faith-sponsored
Yes.
organization. And I'm wondering how the linkage between the spiritual side and of our health and your organization and Texas Medical Center, for example, how that linkage can be established so that there's a support for what you're speaking of from whether it's Jewish or Christian or Muslim, how that spiritual side can be integrated into the health system.
I think it's somewhat integrated into the health care system in the sense that there's pastoral care within hospitals. But what I would really love to see the faith community do is embrace this conversation about health, not just health care. We know that spirituality, connection to community, a faith community or otherwise, is one of the determinants of health. And so there's an opportunity through faith communities to improve people's health. But I'd love to see the faith community have these conversations, and particularly the conversations around end-of-life care, because that's a safe space to have them. I don't know if I answered your question.
When it comes to allocating resources to non-healthcare health versus healthcare, do you think there need to be different allocations between age groups? So I understand the value of preventing conditions before they occur, but I'm also thinking about people who have lived with a lack of green spaces or a lack of access to healthy food for decades and might have this accumulation of chronic conditions.
So you're asking about allocation of resources among age groups?
Between health or non-healthcare health and healthcare between age groups.
I'm not sure how to answer that about between age groups. I guess I think about it at the community level and think about the factors that make a community healthy, which would include green space and access to high quality food. I'm sorry, I'm at a loss to answer the age group question.
What are a few of your initiatives that you have at the foundation that you see important for this year, short term or long term?
Well, I'll tell you what our big bet is. And we've got a bunch of our staff here, so I would love for people here to talk to them about how they're experiencing our work. So we are making a big bet. We just have a new strategic plan that came out at the end of last year. And what we are trying to do is work through the community-based clinics because they have one foot in the healthcare delivery system and the other foot in the community. And we want to work with them so that they can be the conduit as we pull dollars out of the old acute health care delivery system into primary care and then upstream into ultimately community prevention. And so we're working with a number of clinics across our region to help build their capacity to be strong partners for managed care organizations and strong partners for hospitals so that they're able to play at that table. I would say that's the biggest single thing we're trying to do. And what we're not doing is paying directly for these other factors. And the reason we're not doing it is because we think we have more than enough money in the system. It's just not in the right place. And I don't want to let the health care delivery system off the hook by saying it's okay that you're not paying for health, we'll go pay for it. I want to help the health care system where all the money is locked up move that money.
Hi, Elena. I actually just answered the question before I get to my question about the faith-based. I'm with Harris County Public Health, and we've recently been doing a community health improvement planning, and we've engaged several sectors, including the faith-based sector. So we're trying to begin that conversation, get them involved with health and health priorities in the area. So that's one example. Just wanted to point that out. But as far as the question, we know the budgets at all the different levels are bloated or difficult, and there's financial difficulties. So given the social services is a broad area, are there specific areas, whether the homes or environments or climate change or whatever, are that you've seen are most impactful to go after or prioritize? Is there any particular ones that you feel like have the most impact on health?
I think where the most concrete data and link has been established is in the housing space. I think the movement to move more dollars into the other so-called social determinants is newer. In fact, we were having this conversation in our office yesterday that the data is in a developmental stage because this work is relatively new, pushing the health dollars over and measuring whether or not that actually improves health outcomes. But there's a pretty strong correlation between health and housing and a research base to go with it. And there are lesser bodies of data for the others. We need to build that data.
Texas, like most Republican states, have not accepted Medicaid expansion. Our county judge, Ed Emmett, would like to have it, but Governor Abbott will not even discuss it with him. We are losing millions of dollars that could be used for health care for poor people. So don't you think we should put pressure on Governor Abbott and the legislature to accept Medicaid expansion in Texas?
Absolutely. We have been advocating for that. I mean, Vivian and I started advocating for that as the ACA once we learned that it was optional, and that is something that we've advocated for at the foundation and have talked to everybody we can about it. Yeah, absolutely. And in the absence of Medicaid expansion, we have the compounded problem of people who are uninsured and how they do get access to any care, much less any health. no, this state has not done its job in ensuring that people can live a healthy life.
Hi there, Elena.
Hi.
First of all, thank you for your incredible work that you've brought to Houston and developed for us. I think most of us have had these conversations in our head, but you so eloquently and very easy to process delivered that today. Wanted to ask you a question about Hispanics and diabetes and what your thoughts are in regards to that, because of the challenges around chronic disease management. But at the root of that is behavioral change. So can you talk to us a little bit about what your thoughts are looking forward? What can we do? How can we impact this culture to possibly shift their health behaviors?
That's a tough one, and it's not just that people refuse to change their behaviors. There are many people in the populations we mostly focus on don't have the ability to, I think I'll start buying all my vegetables every day at Whole Foods. And so the solutions are tougher. What we'd like to see is that the clinics and doctors and nurses, the health system that sees those patients, gets involved in their communities to solve problems like inadequate access to healthy foods, inadequate access to green space or safe walking conditions in their communities. We really are looking to the health sector, the health care industrial society, as some people call it, to actually deliver health. And they have a strong voice. The healthcare industry and doctors in particular have high levels of respect in the community. And if they will advocate for these things in the community and advocate that healthcare dollars get used for them, I think that moves us closer.
Hi. I'm a retired RN. I've practiced both at Ben Taub and in HISD as a school nurse. And I think we have a fantastic opportunity with the Episcopal Health Foundation to make a big difference. I wondered if you could brag a little and explain how much principal EHF has and what your spending was last year. And I'm interested in how that spending broke out between policy studies and direct care.
Okay, I'm not going to be able to quote you the percentages, but you can look on our website. Actually, I think our annual report is coming out. Okay, we have $1.3 billion in assets, and they are invested. And our spend for this year, our operating budget for this year is $47.5 million. In addition to grant making, we also have a research team, so we generate research in-house. We also buy research, not through grants, but we contract with generally academic institutions and sometimes think tanks or other kinds of research organizations, and so we spend money doing that. We have a team of people that work with congregations and with community organizations to teach community engagement skills, and so we're doing, what am I leaving out? Evaluation. Have I covered everybody? So we're doing more than just grant making. Our grant making for this year will be 30-something million, and the rest of the money goes to support the other programs and then just management in general. We have grown, so the foundation, this is really our 5th year of real operations. The board wanted us to learn how to do the work before we started really spending a lot of money. And so this is our biggest budget yet, and we have grown from about a $15 million budget each year as we've gotten better at doing the work. In terms of the split between clinics and policy, more dollars will be in clinics. I can't tell you off the top of my head. We've got grants people down here who might be able to recite that. They're saying they can't. We love the policy work, and we do fund several policy organizations, and we play in the policy space ourselves by the research that we do and the writing that we do, and spending time with elected officials to try to convey fact-based information.
I just couldn't resist the opportunity to go back to the Medicaid.
I knew it.
expansion and the connection between coverage and Medicaid expansion and improving health in the states that have done the Medicaid expansion, and very clearly in California and Oregon and Washington and other blue states. But the state to really look at is Ohio, which is a red state. Governor Kasich there has done a lot of work, and they expanded Medicaid. And there, like every other place, the managed care organizations have figured out that housing is a big part of lowering healthcare costs and improving outcomes at the same time for those people. So that so many of the people that are homeless now or in Houston don't have Medicaid at all, or employer-sponsored insurance. They have mental health conditions. They have other things that if we could manage those conditions in a more effective way by including housing, tremendously better outcomes for them and saving those states money. The other challenge that we have in Texas is that whenever the managed care organizations who are capitated save the state money, the state then reduces how much they pay us the next year, so that we don't have funds to do these other kinds of things. And so we're trying to figure out always how to find extra money in our existing budgets, because all the managed care plans, it's not just Community Health Choice and the nonprofits, but United Healthcare and other folks in the Medicaid managed care space have all figured out that to control the costs on the health care side, there's these other services that we should be providing. And so I think you're starting to see all of the insurance companies move this direction, which I think is a very encouraging thing. As usual, there's no question. It's just a short speech.
Right.
Yes. Thank you so much for addressing healthcare providers and their torn hearts in this, because I am one of those. And so I work in a faith-based charity clinic and very much appreciate those comments that have been made. We also work with the diabetic population that you were talking about. And we are working really hard, I feel, beyond our resources to be in homes, to do cooking demonstrations, to do counseling. We have a CHW program. And our patients are not receiving elaborate, expensive medical care like an MRI for low back pain. But our challenge has been, how do we maintain the basic medical care that we do provide, and yet also continue to expand these things that I very much feel, as you do, relate to health. I feel like my foot is on both sides of a chasm, and it's getting wider, and we can't split anymore. So any comments on that?
Oh, gosh. Medicaid expansion, first of all, so that you would have a revenue stream for some of the patients you're seeing who are not able to pay and don't have insurance otherwise. And more flexibility within Medicaid to pay for what drives health outcomes as opposed to medical services. Thank you for what you do.
Again, thank you for such a fantastic talk and such a clear way of explaining it. And I just wanted to address the lady that spoke about diabetes in the Hispanic population. And you also mentioned very simple measures. I am a professor of Spanish at the University of Houston. I teach Spanish for health professionals. And we have had undergrad students going to clinics to doing internships, working with the non-compliant Hispanics that have been with long-term diabetes out of control. 6 weeks of working one-on-one, very simple cooking instructions, social instructions, instead of handing them a pamphlet. So I think you addressed the issue, right, of talking to people, asking what is their priority, not your priority, not what you have on your list of what to do, but what is important to them. And I think effective communication for some of these marginalized populations is also key. So thank you so much for bringing all of these issues, not just the health care. Thank you. Thanks.
You coming up?
Well, thank you so much, Elena, for an enlightening talk. This was an excellent discussion about health and healthcare, and as well, thank you to the audience for some very provocative questions and for answering these in a terrific discussion. The presentation will be on the website, so I encourage you to tell other people about it, and you can visit and watch again. And I encourage you to come back and visit us for another talk at further on down in the year. Thanks so much again.